evening, everybody, and thanks for having me here today. It's I would say the presentation of Dr. Anthony was definitely very candid and to the point. I just wonder, having listened to prescriptions, I think, for the better part of my life, we have such good ideas, but the implementation leaves a lot to be desired. So I'm not going to give recommendations. I'm going to only share, number one, what is this whole thing called budget? Promise after promise, nothing gets done. So if you're not willing to invest, then obviously one will have the kind of low rankings that one has seen and which Dr. Anthony alluded to. So that is not something which we can really debate upon. But what we can do is to look at some of the things which happened during COVID-19 of 2020 and 21, and what lessons can we learn from that. I would say that this is not a government versus private or public sector versus private sector story. And I have a number of slides, not too many, maybe about 10, 12, which are very explicit and have been done with a certain amount of research by people who are interested in this. And I've given the sources. It is not a research paper. It is not a Ravi Duggal paper. It just gives you an idea. But before I go to the slides, I do want to say that we should have some clarity, because if you look at, say, we were able to look at a range of about 180, 200 districts. In the country, the COVID beds of the private sector, I mean, allocated through government orders or through whatever mechanism, it was 44%. The rest was with the public sector, district level. Even so, what really came out was that the occupancy in the private sector was much higher than in the government sector. So that really questions when you are desperate, it's a matter of life and death, you aren't going to think of how to save your parent or your spouse or your child. You're not going to think of money to the extent that, I mean, you have that money to spend. And that is why there is a kind of a you might say demand from the private sector, that from the public, that if push comes to shove, they will go to the private sector, even if it costs money, because the standards and quality in the public sector leaves a lot to be desired. Now, before I go to anything, I want to share with you, many of you know it, but I think it bears repetition. The Mumbai model of how they managed COVID is just brilliant. And I'm so proud that India and one city managed to do it. And I was very doubtful in the beginning. I did not have much faith that this was working. I'm not living in Mumbai, but I am a Maharashtrian. So I do have links with people. So it was possible to counter check. So I started out by asking not the commissioner, Iqbal Singh Chahal, because he's a very public figure and would always give the good news story, but lower levels than that. And I think, having been an ex-IAS officer, we know which buttons to press. So I went down to levels which matter. And what really stood out, the Bombay Municipal Corporation had divided, or it already had divided Bombay into 24 wards. And each ward is self-sufficient in itself. It's like a little municipal corporation on its own. Now, they had a common website. Everybody's names, addresses, everything is over there. Every time there was any kind of a requirement for a test report, they ordered and they tried to, I mean, the court was asked to intervene, but nothing came out of it, that the report would not go to the patient or his family. It would go straight to this website, where the people in charge of the 24 wards had all the authority to be in touch on telephone, to be able to send an ambulance. And how they created 800 ambulances is really, I mean, remarkable. That, I mean, if there's time, I'll tell you about it, but it was something which we must think how to do things imaginatively. So the ambulance would go, they would check the patient, they'd say, you appear to be a case for hospitalization, you appear to be a case for home treatment. The hospitalization cases were just bundled, and the bed and the place was earmarked depending on whether the patient said private or government. That choice he had. If he said private, then it was for this particular 24, you might say, one ward, to decide which was the nearest place which had a bed. And all that was on a website. They could earmark, slot this person, Mr. Kulkarni, and Mr. Kulkarni would be taken to that hospital. So number one, that happened. And if you want, there's an article, a very simple article I wrote for the Quint, which brings this out. It's been published. Second was that the entire, you might say, costing in the public sector was free, but in the government sector, you would pay according to whatever that facility charged by the rates that were prescribed. Now, that worked extremely well because the public did not have to worry about which hospital, which bed, which doctor, which ambulance, which drugs. It was all taken care of and monitored by this mini municipal corporation, 24 of them. Now, this is something which makes you realize that in a crisis, it is possible to do this if you have the will and the wherewithal. If you just have neither, nothing is going to work. And it works only in urban areas. This is not India. But Mumbai is a population, something like 16, 18 million, and comparable to the, you might say, the urban population of Delhi, which is more, in fact, 2022, people say, a million. But definitely Delhi was in a mess. They had not done any planning for oxygen, which Mumbai had done right from May 2020. They had given out tenders, they had the oxygen supply from whatever the unit was, going in pipes to the beds in the public sector that had been already laid out. They had given out tenders for PPEs, which many states, even Odisha had given out tenders. Kerala had given out tenders long before this became such a big thing, because Kerala had had the experience of Nika, so they Zika, and they had not Zika, sorry, Nika. Am I right, Dr. Anthony? Nika. Okay, whatever it is, they had had that experience. So Nipah. They used to go and they went and ordered all this. So you had states which had tremendous imagination, initiative, without waiting for all this top-down orders. That's one side of it. That's the good news. The bad news is that the kind of coordination one expected, it was there in 2020. I talked to several health secretaries, 6 of them, and I wrote about it. I even appeared on television saying it, where they were absolutely in the saddle. They said, we talk daily to the Union Health Secretary, we get inputs, we are told how to do things, and the lockdown was being used largely for ramping up the capacity to find your people, quarantine them, isolate them, take over these dharamshalas, take over the health resorts, make them into centers at the district level. And the Bilaspur example in Rajasthan is absolutely, I would say, positive and brilliant. That fellow, I was talking to him around 25th of March 2020. And he already was able to ensure that the kind of, you might say, cordoning off of the district to prevent people from coming in or going out, and 2 million population house-to-house visits took place, and they were able to stave off. They had about 13 deaths. Not a death after that, because this came from Udaipur. Somebody had gone for a party, people had come from abroad, they brought the infection, but he was able to do it. And I didn't believe him, because I am a very hard-boiled bureaucrat. I know where the loopholes are. So I asked him, I said, I want your data. Before I write an article, I want to see which houses did you go to, what are the names, which are the wards, which are, and he did. On WhatsApp, he sent me sheaf upon sheaf of every subdivision of that district and the sub-subdivision and how they were managing it. And it's a brilliant story, both that and the other story is also of Kasargod, which did extremely well. Anyway, so we have good news stories, and yet we went completely amok in many states and many cities, and later on in rural areas in some parts of the country, it was disastrous. Whatever good chits may be given to anybody, the fact remains that these pictures of dead bodies being thrown around and pyres and bodies in the river, no, they could not have happened. I mean, nobody is going to make up such a thing. And that has to be avoided. Now, let's get back to the bigger picture, which is that I want to put up my slides. And basically, I am not trying to push for the private sector, but do realize that foreign direct investment into the health sector was permitted by government policy. It was permitted with full finance ministry approval, not health ministry. We were nowhere in the picture. I was very much in the ministry when all this was happening, and it was not a decision of the health ministry. We didn't even know it had happened. FDI came, and with it came lots of money pumped in as a business. Remember, it was never for altruism. It was never for charity. It required regulation by the government. And I think I must have written 3 articles by now on the subject that we do not have a regulator. Telecom has a regulator. Electricity has a regulator, and you go from level to level, up, district to state to center, and it works like a court till finally it goes to the courts if everything fails. But I know very well that the regulation is pretty tight, and if the regulation can be tight for these sectors, why can it not be there for health? Instead of blaming the private sector that, oh, they make money and they are extortionists and they are cheats and they are just, sucking patients dry, they will. All businesses do it. It's not special to health. Just because it's health, you don't have to show compassion. Every single business, and Dr. Anthony mentioned in some context, he did say that this kind of a tendency to make money wherever it is possible will be made. It is for the regulator to manage this whole thing. There is no regulator. Clinical Establishments Act will never come. Take it in writing from me, Dr. Anthony, because even the few states that have done it have not issued the rules, or they have not appointed the people to do the oversight. So it is as good as non-operational. It is because it hits exactly where the private sector should be hit. Now, I'm not talking about corporate sector. I'm talking about the private nursing homes, small fellows. They take anyone off the road and treat him as an assistant. He later on becomes a unqualified medical practitioner. They take any girl, put her in a white uniform, and with a little bit of training, she's called a sister or a nurse. If you have the Clinical Establishment Act, you will have to notify who are you keeping, what are their names, what are their qualifications, and what are the services you're giving. If you're doing only maternity work, you cannot be doing something else. If you're doing surgical, general surgery, you cannot be doing some specialized work. So the Clinical Establishment Act asks for transparency, which none of these private hospitals want to give. That is why IMA has opposed it tooth and nail, and they will continue to oppose it. And governments ultimately listen to where the strength lies. And the strength, the public never takes this up. Like public everywhere is complaining, but they never get together to articulate it. I'm glad that the policy circle is at least trying to give a podium for these things to come out. But anyway, clinical establishments will not come, with the result that you do need a regulatory mechanism and not the consumer courts. They are busy with toasters and with air purifiers, and in the middle of it, you have a medical negligence case also. I don't think that that is the way. You need a proper regulatory system for the district level, state level, and the upper level. Now, I'll come to my slides because they talk about insurance, and I am a great votary for the fact that, like other countries, either at source money has to be deducted from people, and that cannot be, I'm not talking about the below the poverty line or the poor. They have been catered for in whatever way it is happening under Ayushman Bharat. What happens, as Ravi Duggal told me, what happens to the middle class, informal, white collar worker? And I'll share with you the details of how large that segment is. They have no insurance cover, and they do not have the money, they say, that even if they're earning, to be able to put in 45,000 or as a premium is something which comes dearly. And if there's a parent to be looked after, then it's really something which becomes suddenly shoots up from 45,000 to 90,000. So this is something which insurance will have to obviously build in. All over the world insurance works like that, so it's no use blaming the avaricious and insurance companies. The fact is that if you need health insurance, it is for a certain amount of money. So straight, let's go to my slides. So I'll have to do screen sharing, I think. Can you see? Is it visible?
Yes, ma'am.
Okay, I think it needs to be made into a larger thing. Okay, now you can see it?
Yes, it's visible.
I don't know. It's gone back again. I don't know where it's gone. Anyway, this slide 2 is there. Slide 3, I'm going straight into. Now, this is something I've missed 2 slides. Forget it. They're not worth it. This one is something which you must have at the back of your mind when you talk of private sector. 2/3 of the hospital bed capacity is owned by the private sector in India, the hospital bed capacity. Hospital bed distribution is nearly 62% of this bed capacity is with the private sector. And of the 11.9 lakh private sector beds, the top and large hospital chains, I've given the names below, they account only for 4 to 5% of the beds, while the rest, that is 95%, is owned by smaller standalone private hospitals and nursing homes. So when we talk about the performance, when I share with you the performance of the private sector, which I know about, I'm talking about the 4% to 5%, not the 95%. I have anecdotal evidence what happened in the 95%. Very generally, they folded up when they were very small. If they were just 10-bedded facilities or something like that, or 20-bedded, they just folded up because they just didn't have the staff. People went away. Some opened for certain other things like maternity services and all, because they found they were completely without any kind of work, any kind of earnings. But that was also very small. They were, who was permitted to be keeping the COVID patients was very much under government's eye. Of the 95%, how many were allowed to actually keep COVID patients? I don't know. But when we talk about large hospitals, let us be clear that I am referring to Apollo, Max, Fortis, Manipal, Narayana, this Medant and Aster DM, HCG, CARE, and large regional players like your Shalby and Sterling and Sayadri and Amri and Kims and things like that. They are the regional fellows. Now, those certainly fall in this 4 to 5% bracket. Bed distribution is on your left side, and you can see how large the private sector beds are, the bed distribution, that is. The blue is 62% and the orange is 38%, which is public sector. Now, the next one is, how do I go to the next one? Okay, let's hope this is the right slide. Okay. Now, what the large private sector did, these are positive stories, these are not negative stories, but they throw up policy issues. First is they did set up teleconsultations. These were facilitated, and I know people, at least in my locality, who have availed of it. Whether they cost 100 rupees a day or 10,000 rupees a day, I'm not going into that. That is for a regulator to go into. But they did facilitate teleconsultations. That helped to have doctors on call 24/7. Where else could you get to talk to a doctor 24/7? They established these flu clinics at the entry, so the employees and the visitors were also screened, which is good because they did it without any instructions from above. They had to be very careful about who they're letting in, but they did it. They ramped up their infrastructure, and I talked to managements in 2 or 3 of these large hospital conglomerates, and they definitely spent the capex money on very fast. They didn't wait for anything else to happen. They got these, they're listed there, laryngoscopes and smoke evacuators and intubation chambers. And they got all these things, the ICUs, the ventilator beds, and all were ramped up. We still fell short in Delhi, terribly short, but the fact remains that they did do these things, and all these chains, most of these chains did it, and they did not wait for hand-holding on these things. They also listen to state governments. I talked to the 4 state governments, certainly Kerala and Orissa, not Orissa, Kerala, and the second was this Delhi, and then I talked to Maharashtra. In all cases, there was no doubt that the state government had full authority, and in the beginning they shilly-shallied, but later on they exercised the authority. Many states issued very copious orders to the private sector hospitals, and they complied. They didn't sit and say this can't be done and this is a problem, this can't be done. That's a good thing that happened, that they didn't start throwing up their hands and saying it is beyond us, this is not the work we do, etc. And they manage their own PPE and their drug supply. At what cost? Again, I'm not going into, this is not you might say a defense of the private sector. It is to show that had this not happened, where were people to go? Except Mumbai, no other state in the country had the networking that Mumbai set up. Nobody had the imagination to do it that way. But wherever it worked, people willy-nilly took a car, took a patient, landed up over there in the hospital. It's not as though all of them had a good time. We know of retired ambassadors who even died in the parking lot. We know that. But within a kind of a, you might say, perimeter of having entered the hospital, there was some way of being able to manage. And I want to share with you a personal example. I got calls from Manila, from a batchmate, and from a very senior person whom I know in Singapore. Both said, please, please help to get a bed. And I tried, no private sector hospital was willing to give a bed. They said, we cannot. There is a waiting list of 400. People are watching with a hawk's eye. We cannot interject somebody from below. They can be on the waiting list, but we cannot give the bed. Ultimately, in both cases, I had to speak to the government setup and beg of them. They need an oxygen kind of a place, a ventilator place. Even then, the poor people had to wait in the emergency for about 2 hours before they were allotted a bed in a government hospital. Things were extremely bad, and I'm talking about Delhi. So I do not know really what may have happened in other state capitals, but Delhi was really quite a disaster for certain days of April and May, certainly. So this is the story of what the private sector did. Again, this is fraught with a lot of question marks. There must have been overcharging. There must have been horror stories about how people were treated. Please don't look on this as a kind of a defense. It is only to say that thank God that India had at least that 4-5%, which did not suddenly throw their hands up. They did something about it. Now, coming to insurance coverage, and this kind of thing has been collected from IRDA, PMJY, and ESIC, Telangana Arogya Sari, and various published articles. I have the links to the articles, but I think that kind of work is much more up the street of Ravi Duggal. It's not my bread and butter, but at least this gives you a picture which you should be familiar with. Now, let's go to this coverage. You can see on the left side, health insurance penetration, the percentage of population covered or eligible under health insurance. This sounds very good, but we know in effect what it means. You see that big blue, the big blue is the government-sponsored scheme, and above that are group policies. Now, if you look at this, one would be very impressed. 74% of Indians are either covered or are eligible for coverage under either health insurance or government health schemes. So the uninsured is 26%, that is 36 crores. People who are white collar, who do not have insurance, who may be self-employed or maybe in companies or in, you might say, non-government areas where there is no insurance offered. This is the middle group that needs, it's not in the middle, but I call it the middle group, which needs to be addressed. Insurance is not really something they have been availing of. How do they avail of it? At the cost at which it is being given, the premium, unless it becomes reasonable and affordable, people won't be able to afford it. The rest of it all is these government sponsored schemes. Now let us go to those government sponsored schemes on the right side. You will see that together there is this 39 crore, 39 crore people, 43% are in this Atal Bihari PMJ scheme. And then there are additional families also under PMJ who are about 20 crore. Together, they are 65% of the government scheme beneficiaries. Whoever is getting government benefits through different schemes, they become eligible for this PMJY. So it's a very, very large number. Do they get it? Do they actually get covered in the hospitals? That's a totally separate issue. From the anecdotal evidence I have, this was not a scheme which was, the PMJY was not being used by the public which needed beds under COVID. They paid out of pocket. The outgo from PMJY for COVID was nowhere near what all those long, long lists of whatever you can cover under PMJY spoke of. So that is one side. Then you have central government. Right on top, you have the PSU employees and the CGHS. Then you have the light blue bar, which is the ESIC, which is about 13 crore people. And then, of course, Telangana, Orissa have, hello? Can you hear me? Hello?
We can hear. Any problem? Only
no,
thing
this, I'm getting
time.
a message that my internet connection is weak, but I'm able
No. We can hear you. Only thing is we have overshot the time because 2 hours speakers are out. Thank you.
Okay, then in that case, what do you want me to do? I've got 3 or 4 more slides.
Maybe
expedited. Okay. So this is the payer mix. You can see that the cash in the pre-COVID time what it was and post-COVID time what it was. You can see very well that the TPA went up phenomenally. The orange went up phenomenally in the increase in the TPA insurance. And here, this is something which shows what did an average patient bill you for 1.54 lakhs. What did he get back? 0. So that shows there was quite a sizable out-of-pocket expenditure. And this is huge differences. Then you have the year-on-year collections. The only short point in this is that retail health insurance went, group health insurance came down, and the government schemes that we talked about coverage was in fact completely below, it was minus. Then the lessons learned and the policy. You can see the kind of health infrastructure that was positioned by the private health sector. The first blue line is the oxygen beds, the orange line is the ICU beds, and the ventilators is the green line. So because the period is April 21, 2020 to April 9th, 2021. So in a year, you can see no great improvement except O2 beds have climbed up now. And the second thing is the ICU beds have climbed up, but not that much. So this was the picture. I'm sure it will get ramped up more. So ultimately, the lessons learned would be building a skilled pool of manpower that is badly needed to enhance private sector participation in Ayushman Bharat. Most of them are complaining that they don't get the tariffs which are even able to pay for their costs. So that is something which needs to be checked. And we have to look at this middle group that I talked about, that 26, you might say 36 crore people who are not insured. What's going to happen to them? I think that's important. And you can see the point that was made, the COVID insurance claim and settlement amount, the state-wise trend is quite different. So one size fits all will not really work. This is basically the kind of stuff I have pulled up, and thank you very much for listening to me.
Excellent slides. Last.
And if you want, this slide is only quotations about all these Bajaj Alliance and Star Health and Insurance Marketplace Policy Bazaar. All of them have said that now coverage under health insurance has grown. Pre-COVID, it was 2 lakh to whatever was happening was about in the range of 20-25%. It has now gone up to coverage of 5-7 lakh. That is a matter of fact. But what happens to people? Where do they get the money? Have to enable people to get insurance, and some sort of the French model. If there's time, I'll talk about it. But right now I'm closing. Thank you.